Welcome to the second Special Interest Group that aims to discuss the adoption and implementation of OMOP across the UK. My name is Jeff Hall. I'm a medical oncologist at the Leeds Cancer Centre, and I'm one of the joint chairs of today's meeting in my role as the Chief Clinical Data Officer for HDRA UK. I'm involved in work in Leeds and nationally on the adoption of OMOP to describe cancer data. And so today's agenda is partly a reflection of that and partly going to be very interesting to me to hear the thoughts of experts. Danny, did you want to introduce yourself and say?
Very quickly, welcome everyone. Delighted to be chairing this session today again. Danny Hambra, Professor of Pharmacoepidemiology and lead for Health Data Sciences at the Barnard Research Centre, University of Oxford. And we have a packed agenda today with guests who know much more than me about what we're going to be discussing. So I will not dwell on my own presentation any longer. Jeff, back to you. I think we have a little poll that we wanted to use to engage our participants today. I don't know if you want to do the introductions of the guest speakers first, and then we move to that.
Yes, perhaps we could do the introductions. Danny, would you be able to do the introductions for me, and I'll just exchange some messages with Alex about the poll?
Absolutely. So we have today with us Craig Saxon. Craig is the Director of Communications at the Odyssey Coordination Center and Odyssey Community. And more importantly than that, Craig is probably one of the people in the world who knows more about all the working groups in Odyssey and all the activity going on behind the scenes to keep the community going. I'm delighted to have Craig on board today for this call. Thank you so much, Craig. And then we also have Professor Asia Golozar, who is a professor at Northeastern University and works also at Odysseus, and she's one of the people who have been doing a lot of work to get an OMOP extension for oncological data, for cancer data, and to facilitate research in that space. And again, one world expert in that specific field. So again, thank you so much, Asia, for joining us today from the other end of the pond, if we're still allowed to say that.
Fabulous. So myself, Danny, and others involved in establishing this meeting were keen to do was to try and engage the community of people who've joined this call. So rather than just talking at you today, our plan is to have some introductory talks, but also to use some breakout groups to try and open the discussion around two particular themes, one of which is the use of fluoroquinolones in the UK. That's work that Ed Pern will talk to, but we'll also discuss that in breakout groups. The other one is ideas around the adoption of OMOP in oncology. But we were also keen to see if we could capture some information from the community who've joined us. So I'm hoping that Alex is going to be able to share a Zoom poll, which I have to say I don't have experience of. So I'm fascinated to see how this is going to go. And so, Alex, these are very simple, very basic questions, but we're just trying to get some insight into the level of expertise that is on the call and also to capture the information. So on my screen, a number of questions have just popped up. I'm hoping that's appeared on everybody's screen. And if people could just spend a few minutes filling this in, then that would be incredibly helpful for us.
Jeff, in the meantime, I will introduce Dr. Ed Byrne, who I couldn't see in my screen, probably because we have too many people attending the meeting, which is wonderful news. Ed Byrne is leading development in the Darwin EU collaboration, which is a very important initiative for the European Medicines Agency to do regulatory studies using the OMOP CDM, and he's leading the team of developers working with me at Oxford. Welcome, Ed. I'm sorry that I didn't see you before.
Fine. So I think the poll can stay open, Alex, can it, while we're hearing from other speakers? So Craig, I wonder if you were willing and able to take the floor.
Absolutely. Can you hear me and
Yep.
see? Okay, great.
We can hear you loud and proud, and your slides are in presenter mode.
Great. Thank you so much. Well, thank you very much for having me today. My name is Craig Saxon. I am Director of Communications at Odyssey and the Columbia University Department of Biomedical Informatics, also a member of the Odyssey Steering Group. And I'm really honored to be here to share a bit about a foundational piece of our community, which is the Odyssey work groups. Before I discuss the work groups, it's critical to understand why Odyssey exists. We are a global volunteer organization with the mission of improving health by empowering a community to collaboratively generate evidence that promotes better health decisions and better care. Now, this is a massive goal to set forth for a volunteer community. So we prioritize our global research in 4 areas. In order to generate meaningful real-world evidence that can impact healthcare, Odyssey focuses on observational data standards and management, methodological research, open source analytics development, and clinical applications. I'm going to get back to these research areas shortly, but I remind you that we are working towards the type of robust, reliable evidence that can inform clinical decision-making around the world. And when I say around the world, I truly mean it. We are a global community. Odyssey has more than 3,700 collaborators across 83 countries and 6 different continents. At last check, there are 534 data sources that we know of from across 49 countries that have mapped their data to the OMOP Common Data Model. And this covers more than 956 million unique patient records, or about 12% of the world's population. We collaborate in a number of ways. We've come together for global symposiums over the last year in Europe, in the Asia-Pacific region, and then last month in the United States. Connecting together, learning from and sharing with each other is one way we collaborate. We collaborate in scholarship, including more than 600 peer-reviewed studies relating to OMOP or the Odyssey, tools, methods, or best practices that have been published over the last decade. This graphic here on the right highlights all the different connections that are made on published studies in our community, and we've been really excited about the rise in new authors. Speaking of studies, we certainly collaborate in big network studies. This year, we had an activity where we ran 4 concurrent studies during the spring, while also teaching our community about some of the best practices and challenges and how to overcome them in network studies. At the start of COVID, we had an amazing event, an 88-hour virtual study-a-thon that kind of set the foundation for some amazing work we did around COVID. And we have had multiple legend studies that have already accounted for several hypertension studies in high-impact journals. We collaborate in open source development, creating a range of tools that empower Odyssey research. In my opinion, though, our greatest sign of collaboration happens within our work groups. So the Odyssey community forms work groups to collaborate and produce evidence, or to provide support for evidence production. Work groups start and develop organically in response to community needs and interests. Right now, we have 30 active work groups, and I'm going to jump back to this page, which is part of our most recent annual report, the Our Journey, which the PDF is available on odyssey.org. You can see all 30 active work groups on this page, as well as the incredible group of volunteers who lead these different work groups. I'm continuously amazed by these people who pour their passion and talents and time into these different teams. Our work groups have regular meeting cadence, whether it's weekly, bi-weekly, or monthly, and they are all facilitated within our MS Teams environment. So Odyssey has an overall Teams environment, and then each work group has its own specific team channel where they can have their virtual meetings, but also be involved in asynchronous chat and file sharing and anything else that is needed to really help a team collaborate in a virtual, global setting. As I mentioned before, these are not people who are paid to run these work groups. These are completely volunteers within our community. And these work groups are always seeking new collaborators. So there's obviously a core number of people in all of these work groups, whether they're kind of more older work groups or newer, but they're consistently inviting new people. And it's really important to continue to bring new people in, both those who want to jump in and actively participate, and we are seeing those people in different work groups, but certainly there are more who are maybe interested in a certain topic or want to learn a little bit more and want to join these meetings and just kind of sit back and listen and learn. And those are critical people to invite as well, because in 6 months or 2 years or 5 years, they could turn into really active participants and bring a new voice and a new idea. And that is how our work groups continue to rise and produce new and exciting outputs. And so we are consistently hoping to bring people into our work groups. So as I mentioned before, there's 4 areas of research, and to really achieve in these areas, you have to be focused on specific areas within these focuses. So I'm going to touch on each of them, and there are a number of work groups. I list a bunch on each page. I'm going to touch on 1 or 2 in each, but please don't take that as any sort of favoritism or anything. I just want to give a couple of highlights of examples of work being done. So in observational data standards and management, we have a common data model work group led by Claire Blacketer, and you can see all of the leads to the side. Our CDM work group exists to enable the community to develop standardized methods, software, and generate evidence that promotes better health decisions and care. You also see we have 2 groups focused on vocabularies. These allow the organization and standardization of medical terms to be used across the various clinical domains of the OMOP CDM. In the areas of, we have to methodological research. We have to ensure that we're using the proper methods in research to create trustworthy evidence. So in the areas of characterization, population level estimation, and patient level prediction. So we have a methods research work group that supports Odyssey's analytic use cases and creates awareness of who is researching different methods in Odyssey or anyone using OMOP, and allows these researchers to the opportunity to come together and connect and discuss these methods. And we have a patient level prediction work group that aims to establish a standardized process for developing accurate and well-calibrated patient-centered predictive models. We have open source development work groups. I specifically will highlight the Hades work group, which works to enable the Odyssey community to perform observational research following Odyssey best practices in the areas, again, of characterization, population level estimation, and patient level prediction by providing a cohesive set of open source analytic software. This work group develops and maintains 35 different open source tools that enable various aspects of observational research. And you can learn about all 35 of these tools in that Our Journey annual report that is available on our website. And of course, we have work groups focused on evidence generation within a wide range of clinical domains. We've really been excited about the growth in these work groups, and I'll touch on that in a second. Our next speaker, Asya Golzar, leads our oncology work group, which aims to provide a foundation for representing cancer data, the levels of granularity and abstraction required to support observational cancer research. I'm going to go back to our Odyssey mission, and I want to focus on one phrase in particular, which is empowering a community. So we have work groups focused on the 4 areas of research, but we also have some work groups specifically focused on empowering people. I'll specifically note our early stage researchers, which was started by students at the Erasmus Medical Center in the Netherlands and UCLA in the United States. This work group looks to create an inviting venue for junior Odyssey community members early in their careers to navigate community resources, ask questions, present research, find mentorship through networking, and seek insight on their career trajectories. They've run an incredible monthly speaker series with different veterans in the community. I think has been terrific to see this group come together. At the bottom, you'll notice a couple of regional focused work groups. But we actually have many more what we call regional chapters, which bring together collaborators in specific areas who work towards addressing those challenges in their geographic location. I'd highlight the Africa chapter, which has made really exciting strides in the last 12 to 18 months. And just yesterday, it's announced that they have 117 members throughout the continent, which is really amazing for our mission of global research. At the 2023 Europe Symposium, the concept of national nodes were introduced. It's a collection of research institutes within a member country. There are already 9 throughout Europe, and that's a number I'm sure will grow. I mentioned before the number of new Odyssey work groups. This has been really exciting to see people take the lead and find areas that they're interested in and bring together people. And some of these work groups are already making a real impact within our community. So perhaps you have an idea that you would like to see a new Odyssey work group, and how can you make that happen? It's actually, we try to make it a pretty simple process. The most important thing needed to start a work group is a focus and a person. Where does your passion or interest intersect with an evidence gap in healthcare or an area that can help enable our community to engage in global collaborative research? So once you get that, that is the key. After that, there's no shortage of people in Odyssey who will help turn the idea into a work group, starting with our steering group, who can just kind of provide a lot of the logistical assistance, some ideas, some best practices, what we've seen from other work groups. The steering group also engages in a number of leadership forums for work group leads throughout the year that we've found to be very helpful, and hopefully helps push the work groups forward. And then once we get there, you can begin your collaborations. If this sounds interesting, I would invite you to check out our workgroup homepage on odyssey.org, where you can learn about each of the different work groups. So if you see on this page, each year we ask work groups to come up with a set of objectives and key results, or OKRs as they're listed here, to not only highlight kind of work that's been done, but also what the work group is hoping to achieve in the coming year. And this will help people who might be interested in the work group know the kind of work that you're focused on, and whether, again, that may align with some of the passions or interests of people within the community. There's also short videos, so we have work group leads present these OKRs early in the year during our Odyssey community calls, which are held every Tuesday at 11 a.m. Eastern time. And I would invite anybody interested in the community to join those calls, because there's a lot of information that we share. There are a lot of knowledge that can be gained from those sessions, but specifically like this year, we did them in February. You can find all of these videos on our workgroup homepage. This homepage will also get you into the different work groups. There's a couple of different ways to join. There's a drop down under our work groups tab to join work groups. There's also a button there you can see in the bottom left to join a work group, which is right next to the work group meeting schedule. To the right, you can see it's a very brief form, fill out a little bit of information, and then you can check as many or as few work groups that you would like to join. And again, this gets you into that specific work group environment in MS Teams, allows you to be part of the meetings, and engage and chat, anything you need to do to begin your journey with any particular work group. I'm really proud of the collaboration and the drive within the work groups. Seeing them connect last month at our global symposium, which is these pictures that you see. It's a reminder of how people with shared values and interest, as well as a community that can help provide the tools to collaborate, can really achieve remarkable results as a team, while also helping the global community move forward in our mission. So please do check out this webpage. Reach out to me if you have any questions or would like to learn more about our Odyssey work groups. Thank you for your time and your interest in our work groups. And I'll turn it back over to you, Alex.
Craig, thank you so much. It's really inspiring to see what a community of like-minded people can achieve when they unite behind a common cause. Does anybody have any thoughts, comments, or questions that they'd like to direct towards Craig? I mean, what I will say, Craig, is I plan to go away and have a look at your links. And I think I've got people I'd be very keen to engage with the Junior Researcher Forum. I have to say there's a number of, I think OMOP is the future of data science, and we really need to engage with the junior staff that are going to replace us in some years to come, so we can capture them early. So I hope we can engage some data science and clinicians in that group.
That would
Are
be
there
great.
other comments for Craig? Or
Yeah, just to mention from experience how easy it is to engage with these groups, and how collaborative they are in nature, and how generous actually with the time these people are. So do not hesitate before reinventing the wheel, before thinking this is the first time somebody has done this with OMOP. Go and check the groups, because the chances are that somebody will have confronted the same challenge before, and you definitely want to learn from other people's experiences before delving into the problem on your own.
and Craig, forgive me, did I hear you say they all run at the same time in the week? In other words, they're all running in parallel?
No,
Or
not at all.
uh,
Yeah, you can. So on that Odyssey webpage, the work groups webpage, right next to the join a work group link is a weekly meeting schedule. So again, some work groups will meet weekly, some meet bi-weekly, some meet monthly. Some work groups have done a really great job of kind of alternating times during, 1 week it's a little earlier, 1 week it's a little later, to provide people different opportunities to make meetings. Asia, who runs oncology, there are several different subgroups that meet at different times during the week to help drive forward their agenda. So no, it's certainly, you can be part of multiple work groups and have meetings. I mean, we've had days on, I think Wednesdays, where we've had 9 to 10 different meetings all at different times. So you really can be actively engaged in multiple work groups and reach those meetings. And if there are meetings missed, we do try to have all of our work groups record their meetings and have those meetings available within the team's environment. So certainly not all, a lot of them have consistent times each week, or every other week, but they don't really match up at all with other work groups.
Brilliant, thanks, Craig. I think there's a hand up in the HDR UK room. I don't know whose hand that is, therefore.
Thank you. That's me. Hi. Thanks, Greg. I'm Paola. I'm the head of Alliance at HDR UK, and very supportive of all of the work that Odyssey have been doing over the years. And actually, I think we are learning from you, and this is more of a comment, but maybe a quick question on how you keep the interactions with the different nodes across the different countries, and how you work with them as well. Because obviously, I know you put the UK Odyssey node as well as one of the newest joining. So I just wanted to understand how you bring those together closer to the work of the general Odyssey work, and to avoid duplication and actually join up when needed.
So that's a great question. And actually, the national nodes have been really led, I think, by Peter and Danny. I'm not sure how involved. Yeah, you've been. So this is a new initiative, like I said, that started, really was announced at the Odyssey Europe Symposium. And so the interactions between the national nodes and the regional chapters of the work groups, I don't think there's been a lot of crossover at this point. Again, it seems like just another area where people with similar interest or challenges that they're facing can come together and do. A lot of this is trying to facilitate communication, because when you are a virtual community and you're not meeting in the same office building every day, each week, communication can be lost. And if you are not facilitating and creating opportunities to connect, there's knowledge sharing that doesn't happen. And again, just like Danny said, maybe 2 people are engaging the same thing, where if they just talked and just worked together, the process becomes easier. Really, that is the entire mission of Odyssey, is you should never go at it alone. Too often people try to answer these challenges by themselves or with their own institution, and we are finding that it's through collaboration and through open science and transparency that real results can be achieved.
Brilliant, Craig. Thank you so much for your time today. It's been really informative. But on the basis of time alone, can I move us on? And Asia, can I invite you to take the stage and talk to us about the oncology extension of OMOP, something that is going to be of enormous interest to me.
That's great, of course, and thank you so much for having me. 1 second, let me share my slide. Can you see this?
Yeah, can you put it into presenter mode?
Of course, of course.
Yep, there we go, perfect.
Okay, well, thank you so much. Thanks everyone for having me. And sorry, I won't be able to see you, so I'm just going to start with the presentation. Just going to talk briefly about oncology. As Greg and Danny did the intro, I lead the oncology work group. So what I'm presenting is an overview of what the work group has accomplished, what we're focusing on, just to give you a general idea. There's a lot more detail. I'm happy to talk about it for a long time, but in the interest of time, I'm just going to keep it very broad. So just a repetition of what we saw this from Greg. We are a big community, over 375 collaborators around the world. We have a large data partners. We're actively collaborating together. We publish, you saw the publication. We have methods library, we have standards, but it's all sound good, right? The question is why am I here and why do we care about oncology? One thing that got us together around 6-7 years ago, maybe more, was we need to start working on oncology and develop standards or work on an extension that will become a part of OMOP later on to answer oncology question. But the question is why? Why can we use the general OMOP approach to do that? I'm just gonna talk about 3 problem spaces we're dealing with and we're trying to solve solutions for. First and foremost, cancer is actually a rare disease. We talk about just looking at a drug label, subrected if the drug is indicated for metastatic non-small cell lung cancer patients who have MET exon 14 skipping mutation as detected by an approved test. Just looking at lung cancer in general, the most common cancer, looking around over 200,000 cases, at least in the US, incidence cases. The moment you cut it into non-small cell lung cancer that becomes metastatic adenocarcinoma, and those sets that have MET exon 14 mutation, all of a sudden from over 200,000 cases, we're looking at 7,000. And this is entire United States. If you want to look into the individual institutions, you're going to come up with counts that are like 20, 50, if you're lucky, 100, 185 across a set of EHR system, which doesn't allow you to do any meaningful sort of research, observational research. And the reality is that the picture is actually worse, because then you have all this indication, like situation of multiple mutations together. So we have a problem. We have a rare disease problem. I can't get the number to do my studies or to get a better understanding about this patient population. Problem number 2 is that cancer needs a lot of detail. It is pretty complex to do oncology research. Very typical examples when most of us want to try to answer that in observational data. It can be as simple as what's the overall survival or progression-free survival of patients, same patients, non-small cell lung cancer, metastatic, who have a confirmed MET exon 14 skipping mutation, who have received oral capmatinib as a first line of treatment. It's very typical that we see sometimes we go up to 8 line of treatment, especially if you're interested in multiple myeloma. Just to identify this patient population of interest, I need to know the histology of the tumor, which is non-small cell. I need to know that this tumor is originated in the lung, so that's anatomical side. Not any non-small cell lung cancer, it is a metastatic disease. So I need to have more information on the tumor attributes. It's a metastatic disease with an exon 14 skipping mutation. And not that entire patient population, only the subset who have received a first line of treatment, and that first line of treatment is a capmatinib. So all of a sudden, just identification of your patient population becomes extremely complicated. And the other problem is that not all of this information is available in the structured data. You've got to figure out where to get it, other resources in the notes, combine them to get to that point. And finally, the last problem is that there's actually no standards. There are a lot of different standards that we're dealing with, but we don't have a good terminology, and sometimes we don't even have terminologies to represent any of these attributes or any of these specific information properly. So you see a name, like, for example, for things such as like treatment episodes or different treatment regimens that a patient gets, there is absolutely no standard. Or when you want to talk about the extent of the disease or how the change in the disease situation from like progressing, regressing, or being stable, we don't have standards. So we have a terminology problem. Just to show you a problem, like how bad it is, this is what we see in terms of representation of lymph nodes across different vocabularies. It's absolutely a mess to identify them and be able to properly use them in an observational study. So for having the whole problem space identified for the past couple of years, 6-7 years, we've been working on a solution, what we called originally an OMOP extension. We called it an extension because we wanted to experiment. We wanted to find ways to answer these problems or come up with solutions. And at the moment, like once the solutions were identified, they're technically a part of OMOP, and we tend to call it either the oncology module or we are a part of the OMOP CDM. So the three solutions are having an oncology network, an oncology module, which is the most important piece of the work that we do, which allows us to do the work. And then I can give you some examples. So thinking about the first example that we did together, from over 2,000 patients, all of a sudden we were like up to 7,000. And then looking at the institution, the numbers are going to be minute. If we have an oncology data, we can actually use those little pieces of pie together to get a better understanding of our patients. I think like for those of us who work in oncology, we suffer, and we've seen that quite a lot, that the work cannot be done in one institution. We need to have the power of a network. We can allow it by what Odyssey allows us to do, but enabling the data partners to adopt the oncology module and be a part of this effort. The oncology module was developed to solve all of the problems in the oncology research. There are three main components. One, representation of how we represent cancer, or what we call it a cancer disease model. So a cancer diagnosis, a non-small cell lung cancer with MET exon 14 skipping mutation, is represented as a combination of a base diagnosis, how ICD-10, for example, represents cancer, combination of topology and histology, plus a set of diagnostic modifiers. Those diagnostic modifiers will give you the detailed information on the different tumor attributes. It's metastatic, it is in stage 4, or it has this specific grade, or it has these specific biomarkers. The second one is cancer treatment model, which allows us to represent treatment information at a composite level. We'll talk about it briefly later, which we know that oncology regimens are prescribed in combination. So we want to be able to identify treatment regimens and lines of treatment. The model allows us to represent data in that format so that we can use it properly in observational research. And later, the most important one is the cancer episode models. What's explicitly introduced in the OMOP CDM is the episode table, and allow representation of continuous periods of disease or treatment that have distinct clinical meaning. The patient is on first line of treatment. The patient has a metastatic disease. Those are called episodes. They can be composed of multiple events, and they're essential for conducting cancer research. So just to give you an overview of the cancer disease model, the disease model, as I said, is defined as a combination of the base diagnosis, histology plus topology, and a set of diagnostic modifiers. So it can be stage, grade, margin, metastasis, dimension, extension, and biomarkers. When it comes to cancer treatment model, this is just a typical, very simple example of like what we expect to see. A non-small cell lung cancer patient is treated with 21-day cycle of gemcitabine, cisplatin, and bevacizumab. So this is what we see in our data. And what we need to do for research is to get the regimens and cycles. That's what we enable to do, to have a location for that representation so you can actually populate it and later on use it. And earlier this year, actually during the symposium, we released a second oncology regimen extraction tool that uses sequence alignment techniques to enable extraction of these information into regimens and cycles. Finally, as I said, the episode models represent continuous period of disease or treatment that have distinct clinical meaning. When we talk about the episode model, we're talking about something like an entire like cancer, lung cancer, which all of these episode models can have children. We specifically, in terms of disease, we're interested to be able to identify disease dynamic when a disease is progressing, regressing, we're still at the stable time, and also the extent of the disease, whether the disease is confined to the organ, it's invaded to the surrounding organ, or it's become metastatic. So just to show you like how it works on a schematic patient journey, we have the patient data, for example, from diagnosis till end of life or end of follow-up. The episode model, we will have like an overarching disease episode called lung cancer. And then we can identify the extent of the disease when the patient becomes metastatic. So that would be from the time that the metastatic disease is identified, the patient has a disease extent metastases. Each time that the disease is progressing or becoming worse, we have an episode of a disease dynamic of progression. And later on, in each between like each line of therapy from initiation to discontinuation, we can identify treatment episodes, first line of treatment, and then late, like as children, we can, or descendant, we can identify the regimens and cycles, and then again, same for second line of treatment. So if you look at all these episodes, you can simply see that how you can use that information to answer a series of questions. I can look at the overall survival from diagnosis, progression-free survival, and the metastatic patients, for example, time to treatment discontinuation, time to next line of treatment, and also be able to do some work to investigate the predictive prognostic value of specific biomarkers. I talked about problems with terminology. So we've developed and we're using some of the terminology. Some of them had to be de novo because did not exist. And we've done a lot of work in identifying proper representation of some of the other pieces using existing terminology. So when we're representing cancer diagnosis, we use base diagnosis, we use ICD-10 as our standard. I'll combine them with a set of cancer modifiers and OMOP genomic that we've developed to represent somatic mutations in OMA. For treatment episode, we use HEMONC, and looking at the episode model, all of these vocabularies have been de novo because we could not find or they did not exist elsewhere. Just want to spend a little bit time on the genomic just to give you an overview because I know this is an interesting topic, especially for those who are working in oncology. What we need to do in the genomic field is we need to turn these genomic variants into feature, right? Without features, we can't do epidemiologic studies. And what I talk about is that this is the information I get. So about met exon 14 skipping mutation, where it has happened, which chromosome, which location, and so on and so forth. And we get a lot of that for different variation that we see. And the tumor, this had to become a feature. Person 1 has it, person 17 has it, and the others do not. That's what we're going to use, and that's going to be our input for any of the analysis or even identification of our patients. And to do that, we have to develop proper representation. And we build OMOP genomic by using several knowledge bases that represent the genomic information, somatic genomic information. This is what you see, where the information is coming from. So far, we have over 120,000 variants representing OMOP genomic, over 600 genes, 19,000 coding regions. This is the state in terms of separating them by variation in the DNA, RNA, protein, or the gene itself. But we know that this is not enough. This is the entirety of all the potential variants found and have been implicated in cancer, over 80 million. We know that some of these are not clinically significant. We're talking about using features in epidemiologic studies. And there are a set of driver mutations that we know they're too narrow. This is where we're going to go. And that is only happening by the contribution of the community and working together to build and empower that. So if I want to summarize everything that I said, the oncology module enables observational cancer research in a network study. We provide, we have the details and foundations that answer a series of questions, let it be a cancer burden, looking into incidence, mortality, characteristics of patients, treatment patterns, discontinuation, using it as benchmarking, or looking at real world outcomes. If you want to think about this work, and thinking about the future of observational cancer research, we started here. This is where we want to go. We want to be able to enable everyone to do that, so we can actually create impactful evidence. We are somewhere in between, a little bit closer to where we started, and we can only get there with you guys joining us and helping making it possible. So I'm going to use the same thing. Please join the journey. We meet in 3 different subgroups, and every 2 weeks. Happy to talk further about that and discuss some of this. But I can show you, this is the general work structure of the work group. Our ultimate goal is enabling observational cancer research, and we have 3 subgroups working on that. The outreach and research, which is specifically focused on doing research, finding fundings, talking with different institutions and bring them in. The genomic work subgroup has been extensively and solely working on representation of genomic data. And then we have a vocabulary and development subgroup, which works on the data and the model and any of the analytic tools that can support that. I'm going to stop here and give it back to you, Alex.
Asiya, thank you so much. That's fascinating, and I've got both a million questions and a clear understanding that I need to let others potentially ask more general questions. So does anybody have questions, comments, or feedback for Asiya regarding the oncology extension? I mean, Asiya, it's been very interesting to me, the oncology extension. We first discovered OMOP probably 5+ years ago, and actually struggled to work out how we could represent cancer in OMOP. And then actually rediscovered OMOP 2 years later, well, 2-3 years ago, when of course the work on the oncology extension had been done, to realize it wasn't just us being stupid and not understanding OMOP, but actually OMOP did need an extension. So now desperately hope, and I'll talk a little bit about work that I'm involved with. I very much see OMOP as a standard that supports collaborative research, both between centres in the UK, but countries across Europe and actually countries internationally. So it's fabulous to hear. David.
Yeah, thanks, Jeff, and thanks. Excellent presentation. Really, really interesting. So David Seymour, Director of Infrastructure and Services at Health Data Research UK. I guess 2 things really. One, actually a general observation. The way I guess this had been presented to me in the past is that sort of OMOP isn't suitable for cancer or research, or wasn't suitable. Whereas actually I think I've took from that a flip side, which is actually we haven't really got any ways of doing really effective observational research, particularly around the sort of the rare disease, particularly during network studies, and actually OMOP and your work is actually enabling that. So I think it's a sort of slightly different positioning, but just fantastic to see. And I guess the broader question was, it feels like this has got applicability to other sort of disease areas as well. I sort of assume that's already probably happening, but is there more that we can be doing to make sure that, as you say, the lessons are then learned in other areas too?
That's a very, very, very great question. And so I have to say that it happened first in oncology, not because we're special or we have special needs or desires or attention. The reason was that, as Greg said, a couple of folks came together with one desire: we want to do observational cancer research, with the understanding that OMOP is not well suited to do that. So let's find solutions, and that was what I presented as sort of a summary of what we've done so far. Same is happening elsewhere. So I've been in a lot of meetings that folks, for example, who are working on MS, thinking about how we can actually create or represent different episodes of the disease, and also in a lot of different sort of clinical areas, there's an interest. It's just that like because of the need, and it's the same thing with the work that we've done with genomic data, right? We need it because we need it for cancer research. It's also like sometimes like if I don't have that, I can't really represent my patients. So the work started there, the work is not going to end there, and there are already like other work groups who are working on using some of that, or even like adding some extension to that, or new ways for representing their needs.
Fabulous. Joseph.
Yeah, hi there. I'm Joe Best. I'm Head of Research Data at Nottingham University Hospitals NHS Trust. We're a member of Odyssey UK. So yeah, very glad to hear about the work that you're doing, Asya, and also to realise that the problems you identified that led to this work are very much real world problems that we're seeing within our organization as well, and that, you know, the gaps in the data and those kind of concrete representations of those elements are there. One of the projects that we're working on is around a data set linked to samples that we hold for consented participants in our bioresource. Is there any discussion around how you would represent those kinds of concepts in OMOP in relation to oncology?
What kind of concepts are there?
Sorry, yeah, concept's probably the wrong word to use, but I mean how you've looked at this work and the staging, for instance, how those kinds of items are then linked back through to the original samples that were taken for pathology. Or
so we've worked a lot on representation of all these elements in an OMOP instance, right? So you can actually properly identify stage of the tumor or anything else that you get from the pathology. Putting it back or linking it back to where it is hasn't been discussed. Doesn't mean that like it's should not be discussed, or there's like I'm not going to talk about it, but usually the work, so the way we do that, and like you guys know, like with oncology, it's a never-ending list of things to do, and we have to come up with priority of what are our priorities and how can we focus. And the way we right now will focus our work and effort is use case driven. Use case is not like I want to study lung cancer. It is like within like the whole different gaps or research question, evidence gap. These are the elements in the data that we have to make sure that we represent. This is the specific sort of like in terms of on-ramp or documentation or training that we have to provide to our data partners. We have that data. These are like the tools that we need to develop to properly extract the information either from notes or from other resources. And that's how we work it. But there are always possibility to do more if there's a use case, and there's also interested party to move that forward and lead that effort.
Yeah, I mean, just to very quickly follow up, the reason I asked that is that when we talk about things like date of diagnosis, looking at when test results come back from a sample, for instance, can be one of the factors in that decision when multidisciplinary teams come together to analyze those results and other pieces of information that have been collected about the patient in the various systems. So yeah, that's why it's of interest. But
yeah. So we're doing a lot of work on data diagnosis, but that so because we get a lot of information from different sources, and the distinction or the decision of which one should we use as the first data diagnosis, because of that as a constant topic of conversation. I'd really would be great if you can join us, because we've done a lot of work even looking at the EHR data, registry data, same institutions, different institutions, to see like to what extent they actually agree, looking into the notes, trying to come up with some conventions and recommendations. At the moment, what we're trying to do is that we can actually represent all like different data diagnoses with the provenance of where the data is coming from, right? Without like giving like a researcher, like putting like a stamp on it that this is the gold standard and this one should not be used. Giving with the provenance and with that information, the researchers can have like better sort of like ways to decide which one they want to use for their own purpose. So that's how far we've gone, but we're constantly evaluating this as a very, very interesting topic. Would really be glad to hear your thoughts and work on it together.
Brilliant,
Yeah.
guys. In the interest of time, and I hope that Tim will forgive me, I'm going to move us on. Tim, I wonder if you could pop your question in the chat, and perhaps Essia may be willing to reply to your question in the chat, because otherwise we're going to get behind, and I think it's important that we give time for broader discussion. So in the interest of convenience, Danny, I hope you don't mind if I just move us straight on to introduce Ed, who's going to talk to us about a study that has been proposed as a UK study. And Ed, the floor's yours.
Great, thank you. Hopefully you can see my screen okay.
There we go. Yep, loud and clear. Go for it.
Excellent. So yeah, thank you for having me. What I'm going to talk about is this idea of developing a minimal viable OMOP data set. So here I'm going to be talking about what's needed for a specific study we're going to be doing later in the month. But it was really interesting in a recent meeting, there was lots of discussion, I think, especially for people in the early stages of mapping data in terms of how do they prioritize what to do, and especially kind of getting things out the door in a timely manner in terms of getting people using OMOP as quickly as possible. So the example I'm going to talk about is the study-a-thon we're planning to do at the end of this month, which is going to be jointly with the MHRA. So in the study-a-thon, one of the two topics is going to be looking at a drug utilization study on fluoroquinolones. So I've just taken a screenshot of the protocol and one of the aims, which is to characterize the incidence of use of fluoroquinolones stratified by year, setting, and then we've got these secondary aims to look at indication, dose, duration. So just to take a step back, I know we're quite short on time, so I'll do a very quick summary, but we've just got this idea of the OMOP common data model sitting in between what's often quite messy source data that's hard for data analysts to interact with, and providing kind of this intermediate structure that can be used to generate reliable evidence and can also support network studies. And we've got this schematic of what that looks like. And really, when somebody's thinking about mapping, it's filling in these tables with patient level data. So this is a big ask, and often it's presented as, okay, we're going to map our data to OMOP. That means let's start filling in all of these tables with all of our source data, which, depending on the structure of the source data, is quite the task. So I think in this presentation, I just want to give like an insight into what you could do with like a minimal data set as a way of starting the process. So if we took the very simplest approach, we could map just two tables. So we've got the person-centric OMOP CDM. So we're going to always need the person table, and we're also going to need this observation period table to tell us when people are under observation in the database. With that, with just those two tables filled in, what we can do is already generate population level denominator cohorts. We can stratify them by age and sex, including people only when they're available in the database. So that's kind of not quite sufficient for research, but it's a long way towards it. And then if we just map one extra table, so the drug exposure table in this case, that's going to allow us to already do research. So with those three tables, you could already do a study to estimate the incidence and prevalence, whether point or period, of a set of drug outcomes, because you've got enough to do your denominator cohorts, and now you've got a table to do your outcome table. So with those three tables, you could already almost do our first objective. So you would be able to talk about the incidence use of fluoroquinolones in the UK over a specific study period stratified by year. We're not all the way there, but just to give some confidence that we're most of the way there already. If we then add one more table, which would be the visit occurrence table, that would allow us to see when individuals were hospitalized. And with that, we could do our full first objective. So with those four tables filled in, we could characterize incidence, and we can also stratify by setting. So we could stratify by primary care versus hospital. We can't yet necessarily do our second, but even even so, we're doing pretty well. So for our second one, what we've really is important is understanding the granularity of the mapping and its completeness. So we've got this drug exposure table, and if we want to do something like duration, which is one of our aims, we need to be pretty confident that we don't just have drug start dates in our data, we have reliable drug end dates. So depending on the type of data, that can actually be quite the challenge to get good information about drug exposure end dates. But if we do have that, we can then build episodes of medication use and do most of our second objective. So we could already do treatment duration stratified by year and setting. If we've been able to do sufficiently granular mapping of the drug, so essentially to a lower level than just the ingredients, we can also do dose. So in this case, we've nearly got the whole way there. So here we can now do most of our second objective, which would be dose and treatment duration stratified by year and setting. So the one part we haven't been able to do yet is indication. So what we would at least need to do for that one is to have a condition occurrence table. So now we need to start filling in all the diagnoses. If we did that with this extra table, so now we've got condition occurrence and drug exposure, we've now got the sufficient data to do the full study that we're planning to do at the end of November. So we can do incidence, we can stratify by year, we can stratify by setting, we can look at indications relative to the index dates, we can look at dose, we can look at treatment duration, and again, for those latter ones, we can stratify by time and setting. So that would be a sufficient mapping to do a first quite considerable research project. And then we can't probably avoid the need in the future to do further mapping. So these would often be needed. So we can get all the way to the extensions that Asia was talking about, but we'll need to also fill in many of the tables. So these would often be needed for especially comparative effectiveness and prediction. So these types of analyses often require more domains to be filled in, especially if, say, for the comparative effectiveness, you're doing some kind of data-driven large-scale propensity scores, then you're going to need as much data as possible. Similar for prediction, if you want to integrate all of those different tables as information from all those different tables as predictors, you'd need those tables to be filled in, right? But this is not to say that they would always be needed, but as we get more into those kind of complex analyses, more data hungry ones, you would often need more mapping to be done. And so that's just like a very brief summary of what can be possible with and what we're planning to do. And just to show that it's also what we plan to do is feasible, I'm just including this previous paper that we did as part of an Odyssey network study. So this was during the height of COVID to look at the different drugs people were receiving in hospital. So this included 11 different databases, all mapped to OMOP. We looked at different drug exposures, and we needed a grand total of 7 tables, and one of those is kind of an optional extra to do that study in the BMJ. So we needed the personal observation table, like I mentioned. So that was to, as I said, identify the overall database population. We needed the drug exposures. So these were our outcomes of interest for this study. We needed a visit occurrence table because we were looking at hospitalized patients. So we wanted to say who was hospitalized, how long they were hospitalized for, and so on. And then lastly, we needed to be able to identify which individuals had COVID-19. And so for this, we needed the condition occurrence table and the measurement table. And at the time, we also needed the observation table because in a lot of people's mapping, actually like COVID-19 diagnoses or even some tests were ending up in the observation table. So that's just a very, like I said, a very quick tour of what a potential minimal viable mapping might look like. I think it's quite a useful idea, especially for people that are starting out with mapping. Probably quite a few people on the call are in that position, and the many Odyssey work groups and many tables to fill in can kind of become a bit overwhelming. And I think this minimal viable idea can help prioritize initial mapping efforts while kind of leaving the door open to continue to add as more research projects come in and get data being used. And I think it's also the opportunity to kind of show the value of what people are doing in terms of mapping to OMOP, in terms of achieving some early wins with the mapping, rather than waiting perhaps years for like the full source data to be mapped. I think probably my advice, if you're going down that route, would be like to constrain the number of domains being mapped. So here, like really the tables being mapped, rather than saying, oh, we're going to map a smaller group of people. Like we're only going to map 100,000 people instead of 1 million. That's probably not going to save you much effort. What would really save you effort is not having to fill in the note NLP table. And also like just mapping some very specific subgroup of the population is also probably not going to save you that much effort, because if you're trying to map their full data, you're probably going to have to do more or less what you'd be doing for the full database anyway. I think we're going to have some interesting discussion a bit later about what a minimal viable OMOP would actually look like. And probably there's going to be more than one that people would come up with. So here I was just thinking that probably the way this would ideally work is based on research questions before anything else. So identifying research questions that are amenable to a minimal viable mapping, and then going from there, rather than vice versa in terms of, oh, we're just going to map some small subsection of the table, but then we get to trying to do research and we don't have enough to do anything. And yeah, and I think it's not to say that you wouldn't want to get a full OMOP version. It's more just to say it would be useful, I would say, of like Odyssey UK and Odyssey in general, if we could come up with some kind of waypoints along the process of getting to that full OMOP, in terms of, okay, if you're able to get to this level of mapping, you're ready to do some kind of research. And then that kind of, I think, will help more and more people get the full way to the OMOP, the full OMOP. And yeah, that's a brief introduction to the idea. And I think Jeff's going to follow afterwards with a cancer version, but I could just pause for questions if we have time.
Ed, forgive me, in the interest of time, can we bring the questions into the sort of the breakout sessions, and I'll ask the next speaker, i.e. me, to be really brief and concise on what is a very similar presentation, and I'm hoping that are my slides now available in presenter mode?
Not yet.
Yep.
Not in presenter mode.
Okay, forgive me, in the interest of time, I'm just going to crack on with it as it is. So I would like to talk about OMOP at cancer. I hope Asya will forgive me. I think I come from the other end of the expertise spectrum. But I am part of a consortium of 6 centres that are working across Europe on observational cancer data, who came together with an aspiration to adopt OMOP to allow a common data model across 6 countries to support federated analysis of data. In the UK, we have a highly comprehensive cancer data set, 360 data items for cancer, 80 items in the chemotherapy data set. And what we realized is we needed to try and minimize that. So the group have defined what we call as the minimal essential description of cancer, trying to minimize the data items that we're aspiring to capture to the absolute minimum to perform effective observational studies. We got that down to 38 concepts that are broadly applicable to everything. Some of them are very study specific. In my own world of ovarian cancer, you couldn't do a study without knowing the extent of debulking at the surgery. So a minimal description that can be extended. And that is going to be used as the basis for 4 studies, 3 traditional diagnosis to death studies in lung, breast, and ovarian cancer. But the one I want to focus on today is the pan-cancer study, because it absolutely exemplifies this idea of where could you start? What is the absolute minimum OMOP conversion you could do to contribute to a study? So this is a study that's going to look at the impact of COVID on numbers of cancer diagnosis, the impact of age and gender on that, and how did the 1 year survival change before, during, and after COVID. So that 38 data item MEDOC data set has been minimized to this: 8 OMOP fields, which I believe, and I look forward to potentially being corrected, that can be mapped to 3 tables. So to know about the patient, we need to know a person ID, we need to know their gender and their date of birth, and if they have died, a date of death. We're only doing the topology of cancer diagnosis, so the lung, the breast, the stomach cancer, and therefore we'll place that as a condition concept, and we'll use the date of diagnosis as the start date. And if we capture the last date a patient came to clinic, we therefore have the ability to articulate the numbers of cancer in the 6 centers across Europe, how that those numbers changed during COVID, whether the change was equal for men and women, the impact of age, but also the first attempt to look at overall survival. But because this is going to be a very short-term outcome, we'll look at 12-month survival and compare the percentage of patients alive at 12 months. But once again, I hope this demonstrates, rather than the idea of let's do cancer OMOP, in which I have to confess I was initially utterly overwhelmed with the size of that challenge, actually there are incredibly useful projects we think that you can do with very minimal data mapping to a very small number of core concepts in a small number of tables that allows you to join the community. And that is the message that Danny, myself and others involved in setting this group up are trying to get across to people across the UK. When we got our Eden funding, we were asked whether we were going to map the whole of Leeds Teaching Hospital's data. That is overwhelming as a concept. There's no way we could do that. The second you start looking at Ed's description of what's needed to look at a drug study, and I hope this to look at a cancer study, this suddenly feels achievable. So in the interest of time, I'm going to stop talking. Our plan now, rather than to have one session, and Danny, let me just sense check that this is the right call, is to break out into 4 breakout rooms to try and make it a little bit easier for people to join the conversation rather than use the a single room. So Alex is going to randomly associate us into a number of rooms, and we should aim to come back, shall we say, 20 past 2, which only gives us 11 minutes, guys.
Right. Yeah, I'll just share from our group. We had a good number of experiences, but I think one consideration that's probably different in different places and very potentially unique to the UK is how sometimes governance can affect your strategy for mapping, right? And how you have to make strategic decisions on what you're going to map depending on when governance will arrive for different types or subsets of data. And Gordon from Dundee shared their experience there, which I can tell you is a success story, not only nationally but also internationally, because they were one of the partners that contributed wonderful data to the phenotyping of thrombosis, thrombocytopenia, this vaccine safety issue that we had to deal with in the middle of the pandemic. I have nightmares when I say that. So I think that was a good summary of our experience. Asia shared also a lot of experiences of what they do internationally and what she's done with other partners. But I think that's a summary of what we discussed.
Fabulous, Danny. Let me go second. So a lot of enthusiasm for the concept of this minimal data set, the idea of start small and grow. Another number of voices had expressed this idea of being overwhelmed by the size of the challenge and really liked the idea of starting small. A really interesting question was raised, forgive me for not catching your name, from a colleague at Genome England about where have these ideas for studies come from and what is the process for this group to start proposing these simple projects that could engage and enthuse. And I think that's a question I didn't know the answer to and would be really keen to sort out. A point was raised, which I think is good, recognizing the importance of the big suppliers here, the role of TPP and EMIS in primary care data, but the role of EPIC and Cerner in secondary care data and other major suppliers of hospital-based systems. And then a desperate call to share, to do this open and collaboratively. So the discussions around concepts and scripts and codes, and if we can embed that into the regional SDE program. So Joe talked about East Midlands. I know Yorkshire are doing that, but actually that if we can get projects running across regional SDEs in a common data model, it allows us to test that other mythical half of the plan, which is the federation that sits behind it, which one day somebody will have a robust solution for.
Fantastic. That's great to hear. I mean, that willingness to work as a community this is one of the advantages of working nationally, right? That the challenges are going to be probably more similar to what you experience internationally. So hopefully the solutions could also be more similar and more in common. Paola, did you want to go next, maybe?
Yeah, I can go next very quickly, and a couple of things have already been mentioned. So general agreement definitely on the minimum viable data sets has been mentioned in the room. So there were mixed experiences in the room as well in terms of having mapped the data to OMOP, and in terms of having tried to come up with a minimum viable data set already. So some conversations are already happening elsewhere as well. We have talked about the importance of identify a use case, and again, the SDEs as well were mentioned. And maybe one of the common things that we can think about would be to link the acute care, GP, and secondary care, and seeing if there is a use case that can address a use of data from multiple sources. And the SDE really present that type of opportunity. And in terms of thematic use cases, people in the room mentioned the mental health research in particular, and they hope that we would cover that as well as other things like diagnosis in secondary care or polypharmacy. So I think I'll stop there. We have 3 minutes left.
Thanks, Paola. And then I hope there's a fourth room. Was it? Was it yourself, Alex?
It's it.
Oh, yeah, that was myself. So very briefly, I think we had quite a few representatives who've gone far beyond the minimal mapping and are almost or have already done the full mapping, which was great to get their experience. And I think it's quite amazing. You have, people from Genomics England, Great Ormond Street, BHF Data Science, the Northwest SDE. So there's really momentum towards it, but there is this big challenge of actually getting to the final map data set. I think, my impression, I guess, in general is a little bit that there is a slight disconnect perhaps between researchers and the mapping sometimes, in that the mapping, people are often given the task, map the whole data set, they do it, and then with researchers waiting and then saying, oh, we'll connect to the database once it's all mapped. So I think there is that need for researchers and organizations to really clearly say what the priorities are, why you are mapping to OMOP, not just, oh, it would be good to map to OMOP, but let's quickly, we need to get this thing done in the next 6 months. So let's map to this part of OMOP and then continue to add to it. So I think, there's just, I've thought, what came through from the room is like the potential to do research is quite amazing in the next couple of years. And really helping people get over the line can be assisted, hopefully, with coming up with some minimal viable data set, but it does require some discussion that I think is more than the last minute to work out what that looks like and what trade-offs are made and what gets prioritized. So I'll just leave it there.
Ed, thank you. Danny, could I go to you for some closing words and thoughts?
Yeah, no, I think this was an extremely important meeting. I think more than I thought it would be. It's only the second time I'm joining this special interest group, and we are really going for it. With a lot of energy and a lot of enthusiasm. So I think we've heard a lot of things that we need to discuss, and I think there is a need to continue the discussion openly and align. I think we need to be very strategic nationally on how we're going to do the mapping of OMOP, the mapping of data to OMOP, and bearing in mind everything that's happening with the SDs and the data at the national level. But delighted to see what happened today, and so much enthusiasm and so many participants, and more to follow. I guess we'll have to continue the discussion in the next meetings. Thank you.